our speaker. Dr. Glen Cook is the director of the Autonomic Lab at Walter Reed National Military Medical Center and an assistant professor in the Department of Neurology at the Uniformed Services University. After completing his residency in neurology at Walter Reed National Military Medical Center and completed a fellowship in autonomic disorders at the National Institutes of Health and a fellowship in clinical neurophysiology at Walter Reed. His clinical and academic interests include autonomic changes after concussions and traumatic brain injury and the neurochemical basis of fainting. Dr. Cook is also an active member of Dysautonomia International's Medical Advisory Board. So thank you for joining us, Dr. Cook, and you can take it away.
Great, thank you, Tegan, and thanks to all of you who are joining in this evening. This really is a treat to have people from a global audience and to be able to share and discuss interesting and clinically applicable topics. Just a brief plug as we start. As many things have returned virtual, our Salt Lake City conference that we initiated in partnership with Dysautonomia International is returning virtual this fall, which may give opportunities for more patients, caregivers, and also providers to join in. So I share this information as a opportunity to advertise this and get the word out. The other important thing for me to advertise is that anything I share this evening is my own view and in no way reflects the opinion or position of the Department of Navy, Department of Defense, or any portion of the United States government. So you know the topic this evening. We're going to be talking about concussion and the autonomic nervous system. And talk about both the clinical implications of concussion and also the way that autonomic changes after concussion may be used to guide clinical care. We're going to talk a lot about physiology and physiologic measurements specific to the autonomic nervous system. We're also going to talk about some of the potential mechanisms by which autonomic dysfunction may occur after concussion. So just by way of overview, most of you are familiar with the autonomic nervous system, but as a reminder, this system is really 5 highly integrated subsystems. And we may even talk about the expanded autonomic nervous system to include other features, but classically, we talk about the sympathetic nervous system, the parasympathetic nervous system, the enteric nervous system, the sympathoadrenal system, and the sympathetic cholinergic system. We're not delving deep into autonomic physiology today, but just a reminder that there are these highly integrated individual systems that have their own independent pathways. Now, these automatic functions of the body are coordinated by a network of centers inside the brain that are associated with each other. And this control network that we call the central autonomic network coordinates the autonomic functions and also integrates them with other functions of our body, both cognitive functions, motor functions, sensory functions that we're aware of. All of this becomes integrated in the central autonomic network. And this central autonomic network then relays information to and from the body through 2 or 3 principal centers or nuclei in the lower brainstem. Those inputs and outputs to and from the central autonomic network travel through the spinal cord, and outputs through the autonomic nervous system relay through these 2 neuron systems to their effector sites to cause changes within the body. So how do we test the autonomic nervous system? Well, clinically, so when I'm seeing a patient in the clinic or one of my colleagues is seeing a patient, the majority of the information that we need comes to us from the patient or sometimes their families. So that history, getting the story. Now, much like Sherlock Holmes in solving a mystery, the clinician needs to ask the right questions to get at the right answer when it comes to the functions of the autonomic nervous system. There are times when the history alone is not sufficient, and we rely on the physical examination to provide additional information about the autonomic nervous system. And recognizing the audience that I'm speaking to, I know that many of you are familiar with standard tests of the autonomic nervous system. So a standard autonomic testing lab is going to perform tests of pseudomotor function, that is sweat function, typically with a quantitative pseudomotor axon reflex test. The lab will perform a heart rate response to deep breathing, measurements of heart rate and blood pressure responses to the Valsalva maneuver, and a tilt table test, typically with non-invasive beat-to-beat blood pressure measurement. There are other tests that are done for autonomic function that are sort of outside the standard autonomic testing laboratory. And all of these things are very important and very helpful clinically, but it turns out that in the vast majority of people after a concussion, these standard tests are normal. And so we have to rely on more sensitive measures of autonomic function to look at these changes in autonomic regulation. One of the assessments that we can do is a power analysis of heart rate variability. So this type of analysis, and you'll see the integral that I gratefully adopted from Wikipedia. This type of analysis, also called a power spectral analysis, allows signals to be broken down according to temporal frequency. So we typically use a mathematical equation like this one called a Fourier transformation that allows us to see how much of a complex signal is changing over a particular time interval or over a particular frequency. Thus, a signal like heart rate over time can be decomposed into high frequency and low frequency components. And those high frequency and low frequency components correspond to different functions of the autonomic nervous system. So we can do the same thing with blood pressure that we can with heart rate, really the same type of equation. We can look at how blood pressure changes over time within a particular frequency range. So in addition to breaking down heart rate changes over time and blood pressure changes over time, we can look at how blood pressure is regulated. And typically, we look at how blood pressure is linked to heart rate through the baroreflex. So baroreflex is pressure reflex, specifically the reflex that responds to changes in blood pressure. So when the blood pressure drops, stretch receptors in the aortic arch and the carotid sinus sense that drop in blood pressure, carry that signal to the lower part of the brainstem, and in response, sympathetic nervous system activity increases to cause blood vessels to squeeze down, resulting in the blood pressure increasing. That drop in blood pressure also signals the heart rate to speed up. So you've got this linkage that as blood pressure goes down, heart rate should go up, and vice versa. Blood pressure goes up, heart rate should go down. And we rely on that linkage to calculate the baroreflex. And that is another fairly sensitive measure of cardiovascular control by the autonomic nervous system. And these types of measurements, power spectral analysis, whether it's of heart rate or of blood pressure, or calculations of baroreflex sensitivity, are pretty straightforward and pretty easy to accomplish using the computing techniques that we have now. And even our wearable devices, whether it's a smart watch, whether it's an Apple Watch or a Fitbit, these things that measure our blood pressure have the computing capability to do these. So when I went out on my run today, my watch told me what my recovery was. It was doing that based on my heart rate variability. So my watch was doing a calculation of heart rate variability. So these modalities are very feasible to employ based on the technology that we have. Now, as we shift from talking about measurement, let's pause and define concussion. So concussion, for our intents and purposes here today, and for the majority of clinical and research purposes, concussion is equivalent to mild traumatic brain injury, or mild TBI. So concussion is a brain injury caused by the transmission of a mechanical force to the head. Concussion can happen with or without a loss of consciousness. Most definitions of TBI, traumatic brain injury, and the definition that the Department of Defense uses grades TBI as mild, moderate, and severe. We're focused today on mild TBI because that's the majority of cases that we deal with. There's definitely overlap when it comes to dysregulation of the autonomic nervous system, and there's a lot that we know about moderate and severe TBI and autonomic dysregulation. Today, we're focused on concussion. And now we pose this question: can concussion trigger a disorder of autonomic function that has clear clinical manifestations? And my answer to that is a firm maybe. And the research that we have on this really comes down to a number of case reports or case series published by my colleagues all over the world, predominantly here in the United States, who have reported various forms of autonomic dysfunction, mostly POTS, that have arisen after concussion. And these references are here, and these slides are available to you. So let me focus you in on the paper on the bottom of this slide. Dr. Boris, in his database from the Children's Hospital of Philadelphia, looked at self-reports of concussion that were temporally correlated with POTS symptoms. So unlike the prior reports or the other reports and case series that I've displayed on the slide here, he took all comers with POTS and asked, how many of you had POTS symptoms precipitated by a concussion? And you can see there on the slide that his number was 11.4%. So what if you do the opposite of what Jeff Boris did? What if you follow concussion patients prospectively or even retrospectively and look for the development of symptoms relatable to autonomic dysfunction? So instead of looking at a group of POTS patients and saying, how many of you had a concussion, What if you take a whole bunch of patients with concussion and say, how many of you have symptoms that may be related to autonomic dysfunction? And here are the two papers that we have in the literature that tell us information about that. These are both retrospective studies. So the prospective study hasn't been done, where you look at people at the beginning, either pre-concussion or immediately after concussion, and follow them forward. These are both retrospective, but again, it's a group of individuals with persistent symptoms after concussion, asking how many of them had symptoms that are in the realm of POTS, specifically orthostatic intolerance. And you can see the numbers there, but it's roughly 20 to 40%. So if we look at individuals who have had concussion, who have persistent symptoms, 20 to 40% fit a clinical phenotype of POTS. That is, clinically, they look like they have POTS. And you can see in the paper there by Heyer and colleagues that over time, many of those resolved. The number of clinical cases of autonomic dysfunction after concussion is small. And one of the challenges in the field is that no one has really looked prospectively for the development of autonomic symptoms or of symptoms of autonomic dysfunction after concussion. But we do have a lot of information about physiologic measures. So we don't have a lot of information about the clinical syndrome. We do have a lot of information about physiologic changes after concussion, and the number of papers that discuss this has continued to climb. So I spoke on this subject 5 years ago at the Dysautonomia International Conference, and since that time, the number of papers in the medical literature has almost doubled. And as we look at those papers that examine autonomic measures or physiologic measures controlled by the autonomic nervous system, as we look at those papers that report these measures after concussion, the majority have looked at heart rate reflexes, usually heart rate variability. A smaller number have looked at blood pressure variability or baroreflex. And the overwhelming message is that after concussion, there's a loss of the neural regulation of heart rate and blood pressure. So concussion causes the autonomic nervous system to decrease its regulation of heart rate and blood pressure reflexes. Now why might this happen? Well, we go back to this central autonomic network that has its output of control through centers in the lower brainstem. And that network is connected by fibers, just like our computer networks that are connecting us all together this evening. If these connections are disrupted, and we'll talk more about how they might get disrupted, at least theoretically, if these connections are disrupted, the components of this network might not be able to do their job appropriately to control heart rate and blood pressure. Now, I mentioned the majority of the papers on autonomic dysfunction after concussion have examined blood pressure and heart rate control. A small handful of papers, 5 as far as I'm able to cull out of the published reports, 5 studies have looked at the pupillary light reflex after concussion. Now, the pupillary light reflex, unlike the autonomic regulation of heart rate and blood pressure that has lots and lots of complex inputs, the pupillary light reflex is a little more straightforward. And these are the things that the medical students and junior residents rotating with us here in neurology have to draw out repeatedly. None of you at home have to do this, but you can appreciate the simplicity that's here as opposed to here. Now, the central autonomic network definitely does have descending pathways that are involved in how much sympathetic or parasympathetic outflow there is to the pupils or to the muscles that control pupillary size. So it does become more complex than this, but the principal components of the reflex are more direct. And those studies that have looked at the pupillary light reflex have demonstrated that there are changes in the velocity of pupillary control after concussion. And just like wearable devices can give us a non-invasive means to measure heart rate that may have lots of application in the ambulatory settings. We use the word ambulatory setting to mean outside of a clinic or a laboratory or a hospital. The pupillary light reflex, while it requires computers to actually measure the velocity of changes in the pupillary size, that's definitely something that can be brought into the field, whether it's the battlefield for the situation in which I have to work and be responsible for, or the sporting arena. So you could have potentially a digital pupillometer on the sideline of a football match or an American football game, or even the boxing ring. Let me just make a comment before we move on about one particular paper that integrates measures, more standard measures of autonomic function with cerebrovascular reactivity to carbon dioxide. So lots of papers, there's been a fairly prominent line of investigation looking at how blood vessels inside the head change with different concentrations of carbon dioxide. And that cerebrovascular reactivity does change after a concussion. That has actually been correlated by Letty and colleagues with symptoms of autonomic dysfunction that limit exercise performance. That is, elevated arterial carbon dioxide pressures increase cerebral blood flow out of proportion to exercise intensity. And that alteration in cerebral blood flow was associated with symptoms that limit exercise performance. So as we get into the talking about why this autonomic dysfunction may occur and why some of the clinical manifestations may occur, that altered blood vessel reactivity may be important. So let's get into some of the more details why dysregulation of autonomic functions might occur after concussion, that is mild traumatic brain injury. So first off, there might be direct trauma, right? So a mechanical force is transmitted to the head, the brain moves around inside the cranial vault. There can be direct stretch injury or even direct trauma as the brain bumps up inside the bony skull. And that is certainly something that happens with TBI. As those axons, those connecting portions of the neuron, are put under shearing stresses, it can cause them to break or rupture. So again, this idea of a network of lots of connected threads. In many cases, we think, though, that the injury is not necessarily a direct trauma, but occurs secondary to changes inside the neurons or even their supporting cells after the brain injury. So the mechanical force is transmitted to the head, and that causes an excess in the release of neurotransmitters that are excitatory. And that excessive release of excitatory neurotransmitters can trigger a cascade inside the cells that leads to their dysfunction and or death. And this illustration that's a couple of decades old now still largely holds true. You can see that the end result is an influx of calcium that can result in injury to the axons, those connecting portions of the neurons. And it goes beyond that with activation of enzymes that cause the cells to undergo regulated cell death. The excess calcium causes the mitochondria, the energy factories inside the cells, to not function appropriately. And so this whole cascade of events that results in cellular dysfunction of the neurons. Now, there's an interesting question about the role of the immune system and neuronal dysfunction after traumatic brain injury. And the idea has been put forward, and this is even something that we talked about at the Dysautonomia International Conference 5 years ago, the idea put forward of a potential autoantibody response after concussion. So we know that traumatic brain injury causes proteins that usually aren't floating around in the body, but are stuck inside the central nervous system, to be released. So a significant blow to the head can cause proteins to come from the central nervous system into the bloodstream and potentially be seen by the immune system, where the immune system could mount an immune response against those proteins. One of the biomarkers of concussion that we've looked at for a long time and has now come into limited clinical use is a protein called glial fibrillary acidic protein, GFAP.
Hold on just 1 second. I think his internet cut out.
I got it flashed a message saying my connection to the webinar had timed out and I needed to rejoin.
Oh.
How much did you lose?
Just like a minute or two at most.
Okay, well, I'll rewind a little bit. I was ranting I was ranting on about this protein GFAP, glial fibrillary acidic protein. So good. Tegan's shaking her head. That lets me know that that part was caught. That
Yep, we're
protein,
with you.
other proteins can tell us about brain injury. So not long after that talk 5 years ago, the neuroimmunology group at Mayo Clinic in Rochester published on an autoantibody driven encephalitis, an inflammation of the brain caused by antibodies against GFAP, this very protein that we use as a marker of concussion. So we've got this protein that's leaked into the blood as a marker of concussion, and now we have evidence that antibodies against this protein can cause brain inflammation. And it causes inflammation around the brain. That's why you see meningoencephalomyelitis. Now, this is a rare condition. The Mayo Clinic group went on to publish a series of 90 patients. And remember, they're a worldwide referral center for these autoantibodies. And so that raises the question of how common is it for an autoantibody response to be mounted against these proteins that could be released after concussion or even more severe brain injury? And the answer is we don't know. We need to look at that. And indeed, that is being investigated. And you can see here there's this publication that talks about a study to do that with two of these prominent proteins that we measure after traumatic brain injury, GFAP and UCHL1. Now, closely related to autoantibody responses is a systemic inflammatory response. And I differentiate those two because the autoantibody response is a targeted immune attack on specific proteins or other structures, in this case involved with the nervous system.
Hey, Dr. Cook, can you share your slides again or share your screen?
Oh, absolutely.
Sorry about that. Thanks.
It looks like it's thinking about it. Is it coming through yet?
Not yet.
It looks like it's
There it goes.
It looks like it's done thinking about it.
We can see it now.
All right.
Thanks.
Yes. All right. So talking about a direct autoantibody response as opposed to a more non-specific pro-inflammatory state. And it turns out that non-specific markers of inflammation, these pro-inflammatory cytokines, if we just classify them that way broadly, are increased 24 hours after concussion. And so one question to raise, yet another question to raise, is how much of the alteration in at least heart rate and blood pressure reflex control, or even other autonomic measures, how much of that is just due to a systemic inflammatory response, and what are the clinical consequences of that? Um, the investigations that have been done regarding that pro-inflammatory state have really focused on the immediate post-concussion time frame, and we need to do a lot more work looking at that possible generalized pro-inflammatory state over time. And I would propose that for individuals who have POTS, who experience a worsening of symptoms after a concussion, that it's likely to be that pro-inflammatory state. And that matches very well with the type of exacerbation of symptoms that POTS patients get after general illnesses, right? So if those of you watching that have POTS, many of you have experienced that you get a cold, you don't bounce back from it in a week. It just takes a long time for you to recover and feel back to your prior baseline. Now, one of the issues that we sometimes deal with after concussion is deconditioning, and certainly prolonged bed rest can cause a temporary POTS-like phenotype, right? Our astronauts, and you see this image here from NASA, our astronauts experience that, right? They return from space flight, and physiologically they look like they have POTS. That's because they're in the microgravity environment. Their bodies aren't having to work against gravity. Years ago, we started taking people with concussion and doing this basically cocoon type therapy. Go in a dark room, stay in bed, don't be stimulated physically or mentally for days. And it turns out that that type of prolonged removal of any type of physical stresses actually makes it harder for people to recover after concussion. The body does need to rest and the brain does need to rest after a concussion, but that rest should be hours to a couple of days. People need to get adequate sleep and they need to be protected from further brain injury, whether it's from another concussion or brain injury from chemicals. And you can see my list of things to avoid at the bottom of the screen there. But after those first hours to days, a graded return to work, return to play, return to duty protocol needs to be instituted. And we may talk a little bit about that later, though I think we'll move on in the interest of time. Now, injury to the head can do things beside injure the brain. One of the things to be aware of after a head injury is the potential for a cerebrospinal fluid leak. And we have enough evidence now to say that a leak of cerebrospinal fluid resulting in cerebrospinal fluid low pressure, that is CSF hypotension, can cause severe orthostatic symptoms and mimic a POTS picture. A prominent way to differentiate post-concussion dysautonomia of the POTS type versus post-head injury CSF hypotension that can cause autonomic dysfunction would be a prominent orthostatic headache, a prominent positional headache that gets really bad when sitting or standing and goes away after lying down. Head injury can trigger migraine, and migraine can be related or associated with orthostatic intolerance. And having whiplash causing a headache from injury to the neck structures probably doesn't really mimic a POTS phenotype, but can cause people to feel unwell and add morbidity to the person who sustained a concussion. So we'll talk briefly about a graded return to activity, where we move people progressively through activities, whether it's returning to their sport or returning to work. And what's important when we're progressively returning someone to activity is if they develop symptoms or findings of dysfunction at a certain level, they should back down a level, whether we call it a level or a stage, before moving forward again. And now how can we assess, besides just the individual's report, how can we assess whether or not symptoms are coming out as they're increasing activities? Well, you'll see I have listed here this neurobehavioral symptom inventory, which is this quick scale that can be done to measure symptoms that may arise after TBI. Different protocols are used, but a lot of groups will use a measurement on a daily basis. One of the questions to pose, though, can we use measures of autonomic function to move people through these different levels, progress people between stages? We know that alterations in heart rate and blood pressure regulation persist beyond the time that alterations in heart rate and blood pressure regulation persist beyond individuals' clinical symptoms after concussion. So could we clinically use these measurements to say, hey, you're ready to move forward and engage in more activity, or like, hey, things physiologically aren't looking quite right, quite back to normal, let's have you back off a little bit. And again, maybe we could do this with a smartwatch or some other non-invasive device that tells us, here's what the person's heart rate variability is. And then we decide to progress them or not. And maybe we do that with a computer-aided algorithm. And I already brought up the idea of using pupillometry, right? Could we use measures of pupillary reactivity to do a similar thing? And I ask, what else? What other measures could we use? Now, again, most of the studies have looked at blood pressure, heart rate, and a few looked at pupillary function. But are there other autonomic measures that we could track that we can use to guide return to therapy decisions? And that question is a good one regarding the utility of autonomic measures to guide rehabilitation. I'll tell you, I've become a little bit more skeptical about their potential utility. And why? One is the lack of complete reproducibility between different studies of autonomic function after concussion. But a bigger one is the fact that the differences between concussed and control groups are actually pretty small, such that the differences become clinically significant. So if you look at a change in heart rate variability in one group versus the other, the change becomes statistically significant, but it might not allow people to be separated clinically. So that statistical significance versus clinical significance. So while groups may stratify, you may not be able to stratify an individual in a way that really helps you guide their return to play, return to duty. One of the other big challenges is that for most people, we're not going to have a baseline measurement. So maybe my heart rate variability is messed up after a concussion, but maybe it was messed up before the concussion. Or maybe something that I ate for breakfast messed it up, right? So because there are so many other variables that play into our heart rate and blood pressure regulation, the clinical applicability becomes more challenging. So I would say it's too early to give up on these measures, but they need to be investigated further in clinical settings that use regimented protocols. Um, I know that my colleagues at the Center for Neuroscience and Regenerative Medicine have tried to use heart rate variability measures to guide exercise rehab, and they tell me they haven't had much success. I've heard anecdotal reports from some other clinics that they think it's decent. So I really think jury is still out. Definitely something to investigate further, but I think it's going to be challenging. So before we go to question and answer, I want to talk about the idea of prehabilitation. That is, can we set the brain up to minimize injury or dysfunction after a concussion? Can we set the brain up to maximize recovery after a concussion? And and how might we do this? What factors might play into this idea of prehabilitation? Um, Years ago, people were talking about using omega-3 fatty acids, supplementing omega-3 fatty acids, and those being neuroprotective in episodes of concussion. There's there are still arguments going on in the literature on this topic, and these two papers, at least as of a couple of months ago, were still kind of the final say. We don't know. We're arguing about this. We really don't have evidence that omega-3 fatty acid helps. What about other things? What about other dietary factors prior to or at the time of concussion? What if someone's in a fasting state? Does that change the way the brain responds to concussion and the degree of symptoms or the speed of recovery? What about sleep deprivation? And for me, in my world, that has is a really big consideration because of the operational setting in which a lot of the people I care for are operating. What about hydration status? Does being dehydrated put the brain at risk for concussion? Um, what about use of chemicals that act on the central nervous system, like caffeine, nicotine, alcohol, stimulants? Like, what about pre-workouts? What about the football player who, before practice, takes his pre-workout and then sustains a blow to the head? Does that put his brain at greater risk? And the answer is we don't know. Um, what about the gut microbiome? Are there, or you know, I say gut, but the other microbiota of the body? Are there other factors about our systems that promote a pro-inflammatory state that may prolong symptoms after concussion? And a fairly recent paper by colleagues within the DoD and the University of Colorado have at least shown feasibility of doing a study using an immunomodulatory probiotic. So the study still needs to be done. And then what about the psychosocial substrate prior to brain injury? And we do know that a history of family stressors and other psychosocial challenges in children prolong symptoms after concussion, and service members with a history of um, psychosocial unhealthy events are more likely to experience prolonged symptoms after TBI. So all of these things play into each other, but all of them are potentially modifiable factors, both before or even immediately at the time of concussion, that we may be able to leverage to improve recovery. So if I recap the things we went over, and what are the take-home messages when you go to work or school tomorrow and someone says, "Hey, what did you do last night?" "I spent my Tuesday night listening to Dr. Cook. What did he talk about?" You're going to say concussion or mild TBI causes changes in the neural control of heart rate and blood pressure reflexes, probably by disrupting the central autonomic network. And there are multiple potential mechanisms that may account for that disruption. Changes in pupillary reflex have been studied, but really regulation of other autonomic functions besides heart rate and blood pressure really haven't been investigated. And measurement of physiologic parameters controlled by the autonomic nervous system may or may not be helpful in guiding decisions about return to play, return to duty. But that's something we need to investigate more. And there's a definite idea that interventions that could minimize a harmful neurometabolic cascade could help reduce the impact of concussion on autonomic dysfunction in the body as a whole. So with that, let's take some questions.
All righty. So thank you so much. We're going to get into some questions here. There's a lot, and there's a lot of really good ones. So I'm going to do my best to pick some questions in the time we have left. So let's see. So here's one. Can you elaborate on the difference between a mild traumatic brain injury with loss of consciousness and a mild traumatic brain injury with no memory of the event? And could loss of consciousness increase your chances of autonomic problems later on?
Yeah, so concussion or mild TBI with or without loss of consciousness. It turns out that if you lose consciousness or not, it really doesn't matter in terms of impact to the brain after concussion. So someone gets knocked out cold, wakes up, they may do just fine. Someone gets hit hard, doesn't get knocked out, is just dazed. That person may have lingering symptoms, or vice versa. The loss of consciousness is actually not very predictive of symptoms after the event. Great question. Thank you.
So is there, it sounds like you alluded to this a little bit with the protein, but is there a way to determine if a person had past concussions? For example, if the patient was in their 40s or 50s but experienced concussions as a teenager when concussions were viewed and treated differently?
Generally, no. You remember the picture that I put out with that network of strings that were all connected together. That picture is derived from a particular type of magnetic resonance imaging called diffusion tensor imaging, where fiber tracts are connected with each other. You can a neuroradiologist might flog me for this one, but you can basically call it tractography. Concussion may show changes in those fine connections on diffusion tensor imaging. The problem is, especially with remote concussion, you're not going to know whether or not that injury was due to the concussion or due to some other event in life, and you don't have a baseline to compare it to. So even that type of study that's not done clinically is pretty iffy. Some people with concussion, especially when it's getting on the more severe side, may show changes on susceptibility weighted imaging. That is not diagnostic of concussion. That is, plenty of concussion happens without susceptibility weighted imaging changes on MRI. But if an MRI were done, and the majority of MRIs done today include some type of susceptibility weighted imaging, if the MRI were done and it showed particular changes that in a given case weren't attributable to something else, there could be findings that could be consistent with a prior traumatic brain injury. So
Interesting.
Pretty hand wavy answer.
That's okay. So this is kind of a double question. So how long after concussion can POTS still be blamed on that concussion? So if they, let's say you are developed and being diagnosed with POTS 6 months after a concussion, can you still blame it on that? And how important is it to determine if a patient's dysautonomia is from a concussion or something else like a virus? For example, if a patient had both a concussion and a virus in the last couple months, how likely is it to be the concussion or the virus, or does it matter?
Yeah. So how long after a concussion could the POTS, would you at least correlate those clinically? And the answer is we don't know, but six months is probably too long. When we look at least triggered inflammatory events, we're looking at days to 1 to 2, maybe 3 weeks after. I think if you've had a concussion and then developed POTS symptoms more than a month afterward, I wouldn't tie them together unless you had a concussion and you were severely debilitated and in bed and became deconditioned and then developed POTS-like symptoms. Then I would say, okay, you developed deconditioning after your concussion and now you've got POTS. That's a little bit different though. How much does it matter to differentiate? I think at this point,
a lot of us, so, as a patient myself, a lot of us are like, we want to know why something happened, and some of us have had multiple things that could have caused it. How important is that in the treatment and moving forward?
So we don't have targeted therapies. So I think in 2021, moving into 2022, I think at this point, it's not important. Now that could change. Let's say we find some specific autoantibody, whether that autoantibody response is triggered by concussion or not. If we say, oh, hey, antibodies against UCHL1 are highly correlated with POTS after concussion. I just made that up. We have no evidence to say that they do, but let's say we find that out. Well, then it would become important, right? Because then we would have something to check and then potentially have disease modifying treatments. So those are things that we need to research. But I think clinically being able to say it was definitely from a concussion or definitely related to this virus and it's a post-viral dysautonomia, I don't know that it matters.
That's good to know. So this question says, is there any reason to avoid transcranial magnetic stimulation therapy for depression if you've had a concussion that resulted in POTS?
Not that I know of.
Here's a similar one. What are your thoughts on using hyperbaric oxygen therapy in concussion recovery in the context of dysautonomia? Is it effective?
The studies that have looked at hyperbaric oxygen therapy for treatment of traumatic brain injury really came out negative. The Department of Defense was a big part of a lot of those studies, and it just didn't pan out, despite us really looking hard at the subject. So it's a little surprising to see still people getting hyperbaric oxygen therapy for traumatic brain injury, regardless of the association with POTS or not. I don't think POTS changes that calculation at all.
Okay. Lots of people want to know. So first, quite a few people with dysautonomia struggle with fainting and worry a lot about head injury and concussion from falls. for that reason. And so can concussion, so if you already have dysautonomia and you have a concussion, will it potentially make it much worse?
So yeah, and actually for me in my clinical arena, that's a much bigger factor. People fainting and hitting their heads. That's way more common than someone hitting their head and then coming in and saying, well, now I don't tolerate standing up. More often fainting patients hitting their head. And that's a huge factor. And the good news is the majority of time that people faint, they actually do okay. Perhaps a little surprisingly, but we definitely see head injury associated with fainting, whether it's reflex fainting like vasovagal syncope, fainting from orthostatic hypotension. So it's definitely something to be aware of. And a mantra that I often repeat to my patients is sit down or lie down before you fall down, right? So it doesn't matter if you're in the grocery store or wherever, sit down or lie down before you fall down, because there is a risk to fainting.
All right, so one more question because we're almost out of time. Are patients that have dysautonomia from a concussion more likely to recover from dysautonomia than those that have it for other reasons?
So I would say generally that's unknown. But if we go back to the two papers that I showed that looked at people with post-concussive symptoms and the 20 to 40% that had a POTS-like phenotype, the good news is from those studies is that like 2/3 of them did recover. And so at least based on those papers, I think there is more room to be hopeful for people with orthostatic intolerance or other symptoms of dysautonomia after concussion. So not totally known. I think the answer is probably there's a better prognosis.
Interesting. Well, we're out of time for this evening. So I just wanted to say thank you so much, Dr. Cook. We really appreciate you and everything you do and being here with us today. So thank you so much.